Okay, so let's get started. So as you know that we always do the Suitcase Club here every month. So basically the Suitcase Club is for weird and wonderful, interesting cases, as well as what is exactly happening in the world of vaccines and infectious diseases. So we're hosting it at our fire station in Rosebank. So fire station in Rosebank, that's where Travel Doctor Corporate is situated, and we're currently in our lovely boardroom, and that's where we're actually hosting the Suitcase Club every month. So you can come in person. We do usually have lovely, great food. So if you can come in person, do. Otherwise, you can always join online. And then just remember that we do run our GeoSentinel. Please submit any GeoSentinel cases to us via the following emails. Basically, if you see an ill-return traveler with an interesting diagnosis, or even if it's just the common malaria, anything like that, we would love to know about it. You can send us all the details on these email addresses. And then please remember that we do have Shingrix in stocks. So basically, we imported under Section 21. Unfortunately, because we imported under Section 21, it is quite expensive, but at the moment, we're the only ones who are stocking it. So if you do have patients or even yourself who do need the shingles vaccine, please contact us for further information. And then we do stock Lariam for prophylaxis for children and pregnant women as well. And then thank you to Pfizer for actually hosting us tonight. So I'm going to give over to Shamisa. She's just okay, so Dr. Evan Shoul is going to do our talk tonight, but we all know him. He's an infectious disease specialist at Mill Park Hospital, and tonight he's talking to us about vaccine in the older population. So very excited to hear about that. So let's see.
For the intro, thanks for having me. This is a talk I had initially prepared for a menopause congress early in the year. But a lot of it is still applicable. Some slides probably even more so, what with some of the developments at the CDC. And so we're going to be talking about just some of the main vaccines that we recommend in adulthood. So when I was thinking about this talk, I thought about what do vaccines and leopard prints have in common? I don't expect anyone to know the answers, but so it's always in fashion for some, and always controversial also for some. And it's really quite remarkable how the topic of vaccines is almost always in the press. Whether it's something medical, whether it's something political or economic, something geopolitical. This year has been particularly difficult for the vaccine world and for those of us who are very pro-vaccine and trying to get the vaccine message out there. And we'll talk a little bit about that later on. So in the same way that whenever anyone encounters a pediatrician, they feel obliged to recite the mantra that children are not just small adults, and in the same vein, older patients are not just older adults, but they have their own particularities that we have to consider when making clinical decisions. And the one thing in older age group that is particularly notable is this concept of immune senescence, which really just means tiring of the immune system, where the number of active components and the degree of activity of the components of the immune system over time just sort of gradually decide to take a break, and all aspects of the immune system are affected. There's the humoral immunity, cell-mediated, and compromised physical barriers. We'll go through each of them. So the humoral immunity is something that a lot of us have encountered. So these are, this is related to the absolute immunoglobulin levels that wane over time, particularly the encapsulated organisms, but also the serological, the immunogenic response to vaccines. So the antibody mediated immunity, the humoral immunity, is something that a lot of us encounter day to day in patients that come in with shingles, or patients who have previously been vaccinated for something, and maybe that vaccine effect has worn off over time. Then there's the cell-mediated immunity, which in a way behaves not that unlike HIV, in a sense that the T cell response, the absolute number and sometimes the activity of the T cells is reduced. And so these patients are susceptible to things, in the way I think about it, things that patients with HIV are susceptible to. So older people can present with atypical presentations of tuberculosis and some forms of meningitis, shingles, and so that's the result of the cell-mediated immunity. And those of you who work in old age home environments or in hospitals have to deal with older adults who are catheterized or have some physical barrier that's been antagonized. Often skin is frail. There's poor respiratory ciliary function. And so taken all together, we see that the older age group has its own immune signature that we have to consider, and especially for this talk related to vaccines and the vaccine response. So this is just a graphic representation. Being a physician, I would not be doing my job if I didn't include a slide on molecules and arrows, maybe a few cytokines. So this is the start of what's called the immune synapse. So where the antigen starts off with the non-specific aspects of the immune system. So monocytes, macrophages, neutrophils, these are things that just patrol the body, pick up all little bits of protein and foreign material. They process the foreign protein and then either present it to the T cell, sends a signal to the killer cells, produces cytokines, and tries to kill the microorganism. Or there's the B cell component of the immune system, which is really something that we are going to be dealing with, because that is the component that produces antibodies. Now, if you see the Roman numerals in the diagram, that really points to each step in this immune synapse that is compromised or reduced as a result of older age. So we see that the immune synapse, from the initial non-specific presentation to the super duper specific protein production leading to the antibody production that's very specific. Each component of that is affected by older age. Okay, so let's move on to the real stuff. So let's talk about the vaccines. When one considers the literature, and some of us are still suffering PTSD from becoming vaccine literature experts during the time of COVID, you would have read about efficacy versus effectiveness. And the efficacy is how well the vaccine works in a clinical trial, and the effectiveness is the real world situation. And confusingly, when one looks at the literature, these would be depicted as VE. So it's easy to be misled when thinking about efficacy versus effectiveness when thinking about the vaccine literature. So probably sort of preaching to the converted, but the vaccine uptake, and this is from a general review in an excellent journal referencing US literature. So our uptake's probably even worse. But they talk about sort of 50%, which I think for us would be a dream uptake, something that we could only dream of achieving. And there's a lot of reasons for that, obviously. A lot of people think that there's poor efficacy in adults. It lessens the severity rather than preventing the illness, versus in kids, where a lot of the vaccines would prevent the illness altogether. And I think we've all encountered people in our consultations who feel that like, why should they get the vaccine? Because it doesn't even really work. They got the vaccine and they still fell ill, or they still got a cold, or they still got the sniffles, or and so as a result, they feel that that vaccine administration didn't actually prevent the illness. And so part of the counseling that we have to do for our patients, for older patients, when discussing vaccines is really focusing on the lessening the severity. So particularly during COVID, we all experienced this, and annually with the flu vaccine, people think that a less severe episode of an illness is considered a vaccine failure. And this just shows hepatitis B data of how, I mean, and there's lots of tables and graphs like this. This is just one, just showing the waning efficacy over age. And you see the percent in early adulthood, and just how there's a gradual, significant decline over the years. Also, in older patients, often there are comorbidities that potentially compromise the immunogenicity of the vaccine. So there's an excellent vaccines in HIV guideline that we have in South Africa that talks about low CD4 counts, not so much from a risk. I mean, there is a risk for some of the live vaccines, but a risk of not developing a protective immunogenic response. Obviously, patients who are on chemotherapy and on other immune suppressants, all of the three failures, heart, liver, kidney failure. But the discussion that really should be had is how this group is the group that has the most to gain from receiving these vaccines. So how do we increase vaccine uptake? Generally, the literature talks about removing the doctor from the process, that doctors aren't particularly good, or they're too busy, or they're negotiating other discussions with their patients, aspirin and statins and primary prevention and secondary prevention and all sorts of other things in the consultation, and vaccines, because for some it's such a heavily weighted topic. Some or a lot of physicians don't actually get there in the course of a consultation, and so to take that out of the equation and give that task to nurse in a ward or a pharmacist when they're collecting their discharge medication or their monthly repeats, has a far better hit rate. The other thing that certainly I get asked about a lot is which vaccines can be given simultaneously, and then we see the flu and the pneumococcal can be given simultaneously, but at different sites. And then we'll talk a little bit about this at the end, but there's a lot of work looking at vaccinating children to protect adults. So let's talk about pneumococcal disease. when we think about vaccines and pneumococcal disease, there's a whole host of conditions that we have to consider. Some are mild and minor, some are potentially fatal. And the benefit that we can expect is obviously aimed at the more severe disease, the invasive pneumococcal disease. The one question that comes up when we're thinking about vaccines in the pneumococcal world is the nasopharyngeal carriage and this sort of mucosal carriage. We'll talk about that as well. But this slide just nicely encapsulates, sorry, there's no pun intended with that, but encapsulates the sort of clinical spectrum ranging from sort of minor inconveniences, sore throats, to that are still can be quite severe, and otitis media from on one side of this spectrum to pneumonias and septicemias and invasive disease. So, like most things in medicine, it's never simple. There's always has to be two of everything, so that we have a choice, and we have to sort of thrash out the difference between the two options available. So let's talk about the pneumococcus. It has a polysaccharide coating. That polysaccharide molecule, the main antigen that has been exploited for a number of years in terms of developing an immunogenic response. And so that's the molecule that is part of what's called the polysaccharide vaccine, the pneumococcal polysaccharide vaccine. And it sets up a response directly from the B cell that generates the antibodies. It doesn't, if we remember to a few minutes ago, the T cell response is not part of this equation. So it goes straight to the B cell, pumps out antibodies, and as a result, there's no immunological memory with the PPV23, the polysaccharide vaccine. Now, I want you to just focus on that molecule that looks like a jagged edge, the red sort of crocodile teeth. If you have a 6-year-old child like I do, that's crocodile teeth. There we see the conjugate vaccine takes a protein carrier that's linked to the polysaccharide molecule. And we see that the immune synapse, the immune response to this is totally different. That conjugate, that protein carrier goes through the antigen presenting cell, the APC, processes the antigen, passes the message on to the B cell, to the T cell. The T cell passes the message to the B cell, and then we have memory B cells and immunoglobulin development. And those are the memory B cells that can produce these antigens if the body is faced with this antigen. And we see, if you read the sort of fine print under the little blocks, the polysaccharide vaccine, not great for younger kids, no memory effect, and the conjugate vaccine is effective in children, and there is a memory effect. And so just want you to remember that when we discuss the details of the different vaccines. So for older adults, it's indicated for all of those who are over the age of 65, and for those who are younger than 65 if there are associated comorbidities. Generally, not a lot of people remember the vaccine history, and if there's uncertainty, we generally just give it. So the polysaccharide vaccine's got 23 serotypes. It's approved for older adults, and it doesn't prevent mucosal disease. So that's one of the reasons why I included this. because the carriage, the sinus disease, the otitis media, sinusitis, those elements of pneumococcal disease are not covered by this, but it does prevent invasive disease, the bacteremia, and it's considered cost-effective in older immune-competent adults. Now, there's the conjugate vaccine, the PCV13, so it's 13 serotypes as opposed to the 23 with the polysaccharide. So this is often used in kids, and it prevents invasive disease in adults, and we've been using it in immune-compromised adults, and I'll show you the recommendation for that, where both the conjugate, the PCV13, and the polysaccharide, the PPV23 vaccines are recommended. This was data that came out about 10 years ago from the NICD, and it was really an amazing publication that showed in the early days of the conjugate vaccine, we see that there was a time when there were 7 serotypes. So this looked at PCV7 that was subsequently upgraded to PCV13, and just the caseload that we see reducing over time quite spectacularly in the more younger age group, so less than 2, and then 2 to 4 also showed a decrease, and in the older kids less so. So this was one of the first trials, as you can see in the NEJM, that showed the clinical benefits of having the conjugate vaccine as part of the vaccine schedule for younger kids. This is also from the NEJM, also from about 12 years ago, just showing what happens to in adults, ranging from younger adults to older adults, and just how the rate of hospitalizations for pneumonia reduced in time period. So you can see there's packages of time: 1997 to 99, 2001 to 2006, and then finally 2007 to 2009. And this trial was from 2013. And we see the steady decline in hospitalizations for pneumonia becoming more significant the older in the older age groups, and how the benefit in those older age groups increases. So this is from a guideline that came out a few years ago that just shows what the recommendations are for pneumococcal vaccination in vaccine naive adults. So in adults older than 65, plus minus comorbidities, the conjugate vaccine is given first, and then the polysaccharide vaccine can be given a year or more later. In my line of work, where I'm dealing with a lot of HIV patients, most of them are younger than 65. So we've been recommending a similar strategy where they get a conjugate vaccine first, and then the polysaccharide vaccine a year or more later. And then there can be, depending on the age, a subsequent polysaccharide vaccine given 5 years later. So this guideline is easily available, and if anyone wants a copy of it, feel free to get in touch. All right, we can take questions on this at the end if we need. So let's talk about the influenza vaccine. It's a killed virus. Mostly it's trivalent. Sometimes we get the quadrivalent. It's only moderately immunogenic, and there is antigenic drift There's short-lived immunity, so we do need annual injections. So a lot of people ask, I had one last year, why do I need one this year? And so you can tell them it's about the antigenic drift and the sort of change in strains depending on the season. There is a live intranasal vaccine. We don't get that here. So a lot of the trials show great differences in the vaccine efficacy year after year, and depending on the geography, depending on the strain, and very often the protection is incomplete. And I think one has to be quite open with patients about this, because often there's an expectation that if we give the vaccine, that they can sail through winter without too much trouble. But I think we have to be honest and say the protection is incomplete, but it does reduce disease severity, does reduce rates of respiratory illness, hospitalization, and mortality. There's a lot of data about pregnant women, and a lot of data about older adults, which we'll go into in a moment. And so when we think about how do we actually measure the efficacy of these things, it's really quite tricky, because a lot of upper respiratory tract symptoms are the same for a whole host of viral illnesses. We don't do swabs on all of these patients. The hemagglutination antibodies are an imperfect surrogate, but it is the one thing that's often used to give us an idea of how immunogenic these vaccines are. So which influenza is which? There's a seasonal influenza. So this graph is taken from one of the NICD annual epi reports. So the seasonal flu, that's obviously winter months, person to person, spread from upper respiratory tract secretions. The strains evolve continuously, and so we need to update those vaccines. Then there's the pandemic flu. The last one we had was the 2009 H1N1. Initially, it wasn't previously circulating. Now it's part of our seasonal influenza. And then the one, for some reason, that really irks infectious diseases doctors, because people often refer to themselves as having swine flu, but it's often just the seasonal flu. So these are flus that, because they are viruses that circulate in animals, that sometimes cross over into humans. And because we haven't had exposure to these flu viruses before, we are often, as humans, become severely infected. The reason I bring this up is because if you sort of read the usual media, these are the flus that make it into the papers very often, where there's discussions about bird flu or swine flu, or sort of masses of farms of chickens having to be slaughtered because of some form of a flu within the animals that's been found. And there may or may not be humans, a handful of humans that get affected. And these are the sorts of flu viruses that are on the radars of a lot of the surveillance networks around the world, where we got to keep a very close eye on the zoonotic flu, so the bird or the swine or the whichever animal is experiencing it, because as humans we haven't encountered these viruses before. So our response is usually very exaggerated, and humans often become very ill. So thanks to Tina Law for the slide that's sort of been resurrected from an old talk that she did, that just sort of beautifully shows the different antigens. So when we talk about H's and N's, they refer to the signature antigens on the surface of the virus, the hemagglutinin and the neuraminidase. In humans, there's 3 types of H's and 2 types of N's. In other animal flus, there's a whole string of H's and N's in various combinations, and it can be quite dizzying to consider the different H's and N's. The one that we'd be most familiar with is obviously H1N1. The zoonotic flus, either the bird or the avian flu, or flus related to pigs or other mammals, often have higher numbers of H's and N's. And when we think about those antigens, that's often the target of the vaccine. So influenza B is often a milder disease, almost exclusively in humans, and usually has a lower incidence, but still can cause people to be quite ill, as we've discovered. So this is also Tina Law's slide. Tina, if you're online, thank you very much for the beautiful animation. We see a classic U-shaped curve when thinking about flu, where there's mortality in the younger age groups and a far greater mortality risk in the older age groups. And this just nicely shows the morbidity and mortality associated with flu in the older age groups. In nursing homes, for those of you who do home visits in nursing homes, the rate of influenza and the complication rate associated with flu, this is from an older study, just shows how in those who are vaccinated versus those who are unvaccinated, unsurprisingly, there's a high risk of hospitalization, pneumonia, and risk of death. When looking at South Africa, so this was data also done by the NICD a number of years ago, which was drawing on data sort of at the peak of the HIV pandemic. So one has to factor that into the numbers, where if we think about our older age groups, our influenza-related all-cause mortality in older age groups was really off the charts compared to developed countries. Let's move on to zoster. Okay, so a lot of people ask, what's the point of getting a shingles vaccine? Should they? It's just a painful rash. It's going to settle down. But actually, the incidence of post-herpetic neuralgia is high. It increases with older age. So for those of us who work with HIV patients, who are often a lot younger, when they get shingles, the pain lasts for the duration of the rash, and maybe it extends for a week or two before and after. But in older age groups, not related to HIV, but just related to older age and the immune senescence, the neuralgia can last and be incredibly debilitating. And so it's can also come with significant complications, myelitis and vasculopathies, and sometimes meningoencephalitis. So Zostavax has been discontinued, so we won't talk much about that, but there is a newer a recombinant vaccine called Shingrix, and it's shown good results for preventing zoster and also for preventing the post-herpetic neuralgia. So this is a slide just taken from Up to Date, showing the rates of shingles and post-herpetic neuralgia by age. Now, it's quite easy to dismiss shingles and the complications when dealing with younger patients, but I think this graph shows how the older age groups just have this significant increase, not just in the shingles itself, uh, the incidence of shingles, but also how the post-herpetic neuralgia, once we start getting to the over 50, 60 age group, we see it takes a big jump up. And really, it's hard to overstate how debilitating and difficult to treat the post-herpetic neuralgia is. In treating post-herpetic neuralgia, there are a multitude of different anti-epileptics and antipsychotics and antidepressants in various combinations. Often in the older age groups, treating post-herpetic neuralgia is quite a thankless task. It's very difficult to get a good combination of analgesic effect with a lot of the treatments. They have a lot of side effects, a lot of drowsiness, a lot of delirium, a lot of bladder issues, increased falls risk, and it's really quite a hostile thing to treat because the medication has got such a profound impact. The condition has a profound impact, and the medication has a profound impact on the patient. So some of this relates to Zostavax, which we don't need to consider, but we still get asked a lot of these types of questions related to Shingrix, which is the newer recombinant vaccine that was mentioned a bit earlier. There's no need to check prior immunity, whether there's antibodies to varicella zoster, or whether there's been a previous varicella history before giving the vaccine. Another common question is how long after the episode of shingles should we wait? And there's no specific time after the episode of shingles. So this is from Up to Date, and it really just summarizes some of the data. I think we can ignore that. All right. One or two other things that we're going to talk about. So for tetanus, for older adults who are older than the age of 50, there's only half of people will have protective antibodies. If there's no previous documented completed schedule, they should get the series of 3 injections. Now, there's the Tdap, which is a combination of tetanus toxoid, the diphtheria, and acellular pertussis. And if the vaccine schedule's been completed, then we can get the booster dose every 10 years. The ACIP, which is the American Advisory Committee on Immunization Practices, which is now under threat. So they talk about older adults who are in contact with grandchildren having a Tdap vaccine. And that sort of leads to this next concept, which is the cocoon strategy, which is something that we often dealt with during COVID for those who weren't keen on COVID vaccines, or for those who older adults who were at home, speaking to the family, to younger members of the family, to try and protect the older adult. And so when speaking to someone who might have some degree of vaccine hesitancy, someone who's not terribly keen, it's often worthwhile speaking to the family, to other family members, and maybe getting them vaccinated as a means of creating this cocoon, a protective barrier around the patient that's in question. So this was taken from the ACIP guideline, and thank goodness our I knew, or I had a suspicion that these slides would be valuable later in the year. What was happening, but I've blacked out some of the portions of the recommendation that aren't relevant to this talk. But there we see the flu vaccine, 1 dose annually for those older than 65. We haven't spoken at all about RSV vaccine, but we're all very excited for that. That's probably going to be another talk at some point. A Tdap vaccine. So for those who are dealing with either pregnant family members or grandkids, worthwhile having a Tdap top-up. The recombinant zoster vaccine, it's a 2-dose regimen from over the age of 50. And then we see the pneumococcal recommendation that we discussed a little bit earlier. Now, I always feel obliged to talk about flu vaccine for healthcare workers because it's still mind-boggling how few people get a flu vaccine who work in the healthcare environment, who are working with vulnerable people, vulnerable patients, exposed to a lot of potentially infected people, and act as these sort of transmission mega factories coming to work, being exposed to people with flu and then contracting it themselves and passing it on. A lot of us would be guilty of soldiering through a flu infection. We still come to work. It even has a name called presenteeism. And even though with our great sense of civic duty, you think that we doing our colleagues a favor by coming to work, we're actually doing our patients a huge disservice, and our colleagues as well, by acting as influenza transmitters when we come to work not feeling so well. So often we are in a better immunological state than a lot of our patients, so we have the capacity to respond better to the flu vaccine. Patients are often ill, they're immune compromised, they might not have the same degree of a immunogenic response, and so really the duty is on us to get a flu vaccine and try and stop transmission. Vaccination of healthcare workers should prevent the morbidity in workers themselves and morbidity and mortality in patients. So our duty is to first do no harm. In healthcare workers who get a flu vaccine, there's less flu, less mortality among patients and staff, and obviously less time lost to work. And there have been a lot of trials, randomized trials, showing how in hospitals and long-term care facilities, when staff are vaccinated, the morbidity and mortality is greatly reduced. And in the US, there are a lot of the professional societies that endorse healthcare worker influenza vaccine mandates. And there are a lot of hospitals and health systems in the US where healthcare workers are actually prohibited from working in a patient-facing environment if they haven't had a flu vaccine, and it's really considered entry level. And if you have some apprehension or opposition to having the vaccine, then you are not put into any patient-facing environment. And so with that, say thank you very much, and happy to take some questions.
So we do have some online questions. So the first one is there any reason you cannot give the vaccine to a younger individual, like say 45, who's had recurrent or multiple episodes of zoster?
I don't think there's any contraindication. I think it's more that the trials were done in older age groups. I think in people who are older than than 50. You know, in the younger age groups, with the episodes of recurrent zoster, you really have to try and get to the bottom of why is this person having episodes of recurrent zoster. Zoster in adulthood, I'm not talking about older adults, but you know, one episode of zoster is forgivable, whether it's sleep deprivation or stress or travel, or there are a lot of reasons why somebody might get an episode of zoster, but a recurrent zoster for us means going to look for some underlying immune compromising issue. And it would be wise to exclude that first before giving them a very, very expensive vaccine that they might not respond to if they've got some degree of immune compromise.
And then I see someone's hand is up. If you'd like to just unmute yourself, you can just ask your question if you'd like.
Yeah, sorry, just on that line, I've got a friend that's a 30-year-old, and she's had shingles 5 times in the eye, and after having had the Zostavax, but I think the Zostavax had already been discontinued, so whether it was an expired dose, I don't know, from a pharmacy, but she has had a tumor on the pituitary gland and had it removed. It's not all removed, and then they did obviously radiation. I don't think they did chemo, but radiation. Would this be the fact that she's immunocompromised maybe, and that she's getting shingles all the time? So since that Zostavax, she's had shingles twice and 3 times.
Yeah, so if she's had radiation, there's a chance that she might have had a poor immunogenic response to the vaccine. So the other things is just to actually go up one step in the algorithm. I do often find that sometimes people are labeled as having zoster, or they referred with zoster, and we do a swab, and it turns out to be something else. It turns out to be herpes simplex, or sometimes it's not zoster at all. So for people who are presenting with recurrent episodes of what looks like a vesicular rash, we do like to do a swab of a vesicle or even a crusted lesion, and sending that off for HSV and VZV PCR. It's just nice to confirm the virus. I mean, a lot of the times the clinical suspicion is probably right, but especially in situations where there's recurrence, there's a poor response to treatment, it's nice to confirm. The other thing that we often see with recurrent episodes of zoster is underdosing or shortened durations of antivirals for these patients. And so it's worthwhile reviewing the dosing of antivirals that some patients have received as well.
Thank you very much.
There's a few more questions online.
Okay.
You are quite popular.
Okay.
Are there any specific vaccine side effects we need to warn about for the zoster vaccine?
Not that I know of, over and above the usual local skin, local reaction, the usual immunogenic response, bit of a fever, bit of a muscle ache, but nothing dramatic. I haven't heard, I don't know.
I know from our side, so obviously we give the Shingrix quite often, and one of the more common, but not as common as you'd think, is some people just do develop a rash. It's a painless rash. It's usually on the face and things like that, but we haven't seen anything more severe than that. It usually is just the live vaccine side effects that you usually get. So it's the bit of body aches, fever, things like that. But it doesn't last long.
Yeah, agreed.
Okay, and then so this is from someone. We usually recommend the annual flu shot and even the pneumovax to asthmatic adults. However, would you recommend the same for adults who have some milder form of atopy, like chronic allergic rhinitis or chronic sinusitis?
So definitely the flu vaccine. The pneumococcal vaccine in those patients, remember, with pneumococcal vaccine, we don't, if it's going to be given earlier on in early adulthood, there's got to be a good indication. So there's significant comorbidity, because we're not sure of the benefit of repeating the dose later on, or at another time. So if definitely the flu vaccine, there's absolutely no reason why somebody like this shouldn't get the flu vaccine. But the pneumococcal vaccine for that indication in a younger adult would probably benefit from waiting. Yeah.
Perfect. Then I think that's all on the online questions. Is there any questions in person?
That in children who've had chickenpox vaccine and then having a booster, does that have any bearing on them not getting zoster as adults or getting zoster as adults? And should they have a booster? Because the kind of general regime is to do Varilrix at 1 year.
Yeah.
And some people then do it again at 18. And there doesn't seem to be really good kind of guidelines on that.
Yeah, I'll be honest, I'm not very au fait with that recommendation. I have heard about a follow-up booster, but it's not formally part of any recommendation that I've seen. I'm sorry, I'm no help for that one.
People get normal immunocompetent adult gets shingles. Do they have any immune response to that, unrelated to vaccines? If someone says, okay, so now I've had it, I've had my COVID, whatever, do I have to have a vaccine still? Assume that there's some benefit, but is there any data?
Yeah, so the vaccine does produce a significant boost. So even those who have had clinical shingles, and there are other reasons to give the vaccine, so either age related or comorbidity related.
In somebody said, oh, that was terrible, I think I don't want to get that again.
Yeah,
Should I have a vaccine? The chances of getting it actually fairly remote.
Yeah. So for those patients, I would probably wait. But if there are other comorbidities or age related things, then yes. But for a once-off episode, I wouldn't think it's necessary.
And then one more question online. Is it advisable for this adult who has had zoster 6 months ago and still got Shingrix? Is it advisable for them to still have this as it's expensive and maybe still not working?
You would have to see why have they not responded. There's a lot to that question. Is it definitely shingles? Why are they getting recurrent shingles? Why have they not responded to the vaccine? So often we have to look at these questions to see, because if there's anything else underlying, giving the vaccine again is unlikely to be of benefit. So if it sounds like there's some immune issue that would need to be looked at. Yeah.
Anyone else have any questions? Otherwise, I think we'll end the online meeting, but we'll carry on chatting in person. So just a reminder to everyone that we do have Shingrix in stock. So if you do have patients and you do think they are eligible to get the vaccination, please contact us. We can arrange it for even to be sent to Cape Town. We do have our service providers there. So really, if you do have anyone, just contact us. We're available on email. On the top of my head, I can't say the cost right now. I don't know if Sansi can remember it. Per dose, hey? It's about 8,000 Rand per dose. So like I said, it's very expensive because we are importing it under Section 21. Unfortunately, we don't know when it's coming to South Africa, but at the moment, this is how we're going to get it into South Africa. Otherwise, thank you so much for joining Suitcase Club, and please join us next month. And do come in person if you are able to. It's always fun to just chat around the table and get to meet everyone. Okay, thanks so much.